I'm going to share with you some work we've been doing over the last 3 years. We 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 recognize the importance of our communities, the importance of supporting people in the most deprived areas. That was our starting point. And we'd heard about some work happening in Westminster around the Community Health and Wellbeing Worker Programme that originated from Brazil. And actually, we felt that this was a transformational way of working, a way of investing funding in our local communities, away from the bureaucracy of healthcare and local statutory services, because money and decisions get blocked there all the time. We've mentioned that earlier. So we developed a model where we had anchor organisation from the voluntary sector. Now, just to set the scene, there's a long history in Cornwall from our board, ICB board or CCG board before that, of building a relationship with the voluntary sector as a key partner in our system. So that's been going on for many years. So there are trusted relationships now between health, between our VCSE anchor organisations, our bigger organisations. And we wanted to use those organisations, or at least one of them, as our delivery partner for our community health and wellbeing worker programme. So this was the left shift that our board and our non-exec directors and our chair and chief executive have been advocating for many years. It's something that was their vision already, which was great for me because it made my job a lot easier to make this happen. So we have the left shift decision vision in place. We worked with our VCSE organisations, our local primary care networks at the time. This was before we had INTs. And we said, could you work with this model, Community Health and Wellbeing Worker Programme? Very quickly, community health and wellbeing workers are workers given a small population to work with, about 120 households in areas of most deprivation. They work with everybody in that household who wants to engage with them. They are, as I said, hyper-local, universal, so they give proportional universality around the support they give to residents, and they're integrated with general practice. They work alongside social prescribers in our teams. They aren't one or the other. There's no competition here. Social prescribers are referred to by GPs primarily, whereas community health workers go door knocking to build connection with the residents in that area, picking up unmet need, building trust, long-term relationships with those residents. With the support of our board, we managed to secure a 5-year contract with the voluntary sector to deliver. We've now got 9 teams of community health workers across 9 integrated care areas in Cornwall. We have 16 altogether. So if this was all around the trust, so we mentioned it earlier, Sam mentions it earlier as well, relationships and trust are key across anything you do, particularly around neighbourhoods. So trusted relationships with voluntary sector organisations, and then trusted relationships with the residents in our communities. We've got some things I wanted to touch on for you was, again, the relationships, the trust, developing non-clinical workforces within our integrated neighbourhood teams, within our neighbourhoods, is so important. We're going to struggle with, there was a mention of, the reduction in, or the number of clinical workforce because of age, and we need to fill the gap. What do we fill the gap with? And I do believe non-clinical workforce is crucial here. I also believe that having all of these roles that are well known in your neighbourhood, included in multidisciplinary team conversations, meetings, discussions, so everybody is well supported. The commissioning process, the commissioning decision making needs to change. It needs to be transformational, turned on its head, and away from working in silos around commissioning for just mental health or just commissioning for long-term conditions, but commissioning for the population. And by commissioning something like a community health and wellbeing worker program, for example, cuts across all of those. Community health workers, they support children, they support older people, they support people who are unemployed, they support people with mental health problems. It's across the board. You can't just look at individual situations in somebody's life. Um, it all needs coming together. But I don't see the community health book as being the golden bullet to everything. Of course, they do need experts to look into, experts on children and young people, experts on the medical side from their GP practice, for example, experts on mental health. So it was part of a bigger workforce coming together. Leadership, we mentioned that earlier as well. Leadership is so key here. We're developing a local leadership program for what I call my place-based leaders. So anybody who is leading there, and then training, joint training programs. So that's just a quick flavour of what we've been doing in Cornwall. I could talk forever